Welcome everyone to our collaborative conversation series as part of Making Digital Health Real. So this is a mini-series within our broader seminar program, which is exploring different ways in which research skills can create value and support transformation for healthcare organizations and systems by working more closely and being more embedded within this context. And so today we're going to be about AI. And I had the great pleasure of meeting Dr. Wilson Goh when he came to visit us in Melbourne and Lisatron a while ago. And we have shared interests around simulation as well as around consumer and user involvement in areas like AI. So Dr. Wilson Goh is the Chief Data Scientist for the Center in AI Medicine at Nanyang Technological University in Singapore. He's also a senior lecturer at Imperial College London, and we're very lucky to have him with us today. His interests are around harnessing the potential for complex multimodal data sets, really geared towards implementation and deployment of AI solutions in hospital settings with a specific interest. And I think that applied lens, so making this work in a healthcare context, makes his interests and his experience really relevant to us. And Wilson, we're very happy, we're grateful to speak with us. We're really looking forward to it.
Thank you for the introduction, Kit, and thank you also, Shares, for setting up this session. I'd also like to thank all the audience for making time this morning to come for this sharing session. So I'm very pleased to talk to you a bit about some of the lessons that we have learned in bringing digital and AI technologies to healthcare. So this is the talk outline. I've been asked to share my journey into digital health and AI. I will then give a brief introduction as to what is digital health and AI in healthcare. We will then segue into the three main segments of my talk. So the first segment will be on stakeholder engagement. What have we learned so far from the clinician perspectives and also from the AI developer perspectives. I will then talk a little bit about how we can leverage prior knowledge and we can exploit existing information to improve the quality of learning in the AI and how this in turn leads to more trustworthy technologies that can be deployed and accepted. And then finally, I'm going to go into a few tips and also a few of my own perspectives on how we can evaluate an AI model. So initially, I was trained as an informatician and I was quite academically oriented. I did my first degree in life sciences in the National University of Singapore, and then I did my master's in Biomedical and a PhD in computer science in Imperial College London. And for the most part of my academic career, I have mostly been interested in algorithmic development, working on statistical problems. So these things, while they do translate to manuscripts, they don't necessarily have a very big healthcare or social impact. In 2019, however, things started to change. I put out a bid for a Singapore-New Zealand joint grant to work on mental health in Singapore youth, and also on the indigenous Maori cohorts in New Zealand. So that I think led to some very interesting new developments where we actually looked at population data and thought about how we can come up with novel ways to integrate social demographic information, seek out digital markers, and also identify biomarkers, from very rich data sources. I then went on to establish NTU's first postgraduate program in biomedical data science, which features an AI track. So this is when we actually started training people to really get involved into the healthcare setting, into the industry setting. In 2022, I established the Center for Biomedical Informatics as well as setting up the DSAI research program. And in 2023, for some reason, I made a bid for an AI governance grant, and this grant is to look into areas of trust and governance in medical AI. And in 2023, I was invited to join the founding council for the International PIHAP project into how we can develop novel AIs to build a proteomic navigator of the human body so that we can use these for various kinds of clinical and medical applications. In 2024, and only fresh at the beginning of this year, I received a honorary joint appointment with Imperial College to work on dementia and the Internet of Things. The idea, or rather, there are two parts of this appointment. One part is that I'll be working on field testing novel technologies for living for home-based monitoring of pre-dementia elderly, who will be monitored, and we'll be looking at this digital data to predict, who is more likely, right, to undergo conversion, and if so, what does that pre-conversion event look like? The other part, right, is to work on issues of governance and ethics, where we want to know by the incorporation of these novel technologies, what will change, in terms of patient-centric care. How does these new technologies affect the relationship between the patient, the caregiver, and also the clinicians and healthcare providers? And also at the same point in this year, I was appointed as the Chief Data Scientist of the NTU Center of AI in Medicine, which will be formally announced this September. So as you can see, a lot of my work in digital health and AI, right, is really packed in the last 5 years. There's a lot of very interesting ongoing changes, and I think it's a very fertile area for people of various disciplines, whether you come from science communication or whether you come from medicine or even engineering to partake in this endeavor. I think in order to make medical AI or digital health work, I think we really need, right, a rich and diverse integration of various disciplines. Yeah, and so that's my journey into digital health. I'm happy to discuss more on this later. All right. Yeah, but as we set up these things, right, there will be some very interesting upcoming projects. I am involved in a mental health monitoring on the population, primarily focusing on youth. I'm also working on trying to set up an Internet of Things dementia cohort in Singapore to parallel ongoing events in Imperial College. I will also be working on foundation models and large language models for clinical deployments and so on and so forth. So there's a lot of interesting projects in this space. So before I go into my talk proper, I thought it'd be nice to give a sense, of what digital health and what AI encompasses. So digital health, to give a simple, a general definition, is a broad term encompassing all technology-based tools and services designed to enhance healthcare delivery and improve health outcomes. So some examples, and this is not exhaustive, will include telemedicine, mobile health, electronic health records, wearables and sensors, and health information technology. And what about AI in healthcare? So I'm sure everybody more or less has a sense of what AI is, because it is a very important word, or rather a very often touted word these days. But when you think about AI, you usually be thinking about models and algorithms, and this is not wrong. It is an algorithm and a software. And the difference between the standard software is that then AI is meant to approximate human cognition in the analysis of complex medical data. So this is task-driven, and it can include tasks such as performing diagnostics, performing predictive analytics, where you want to figure out what is the trajectory of the health or the disease development for an individual patient or cohort, personalized medicine or personalized care, improving operational efficiency, and clinical decision support and assistance. So I would like to point out that AI and digital health are very closely integrated, and they should not be seen as separate. So a person who is interested in digital health need not necessarily be separate from someone interested in AI models. So in this diagram here, where I picked it up from the NHS report, and this is actually very interesting. For those of us who are involved in education, you may have heard of Bloom's taxonomy. It turns out that it is a version of Bloom's taxonomy for digital transformation. All right, and you can see that in this Bloom's digital taxonomy map, the basal layer is digital literacy, the education and the information dissemination to all essential stakeholders. healthcare data management. So for those of us, right, who are already in the sector of digital health and or building AI models, you know that access to data, the cleanliness and organization of data, it's a really big headache for many of us as we're trying to mine this database for information, and trying to establish the correct labels and so on and so forth. And of course, the incorporation of engineering solutions and digital technologies, right, will generate even more information. But of course, this information, right, needs, right, to be integrated or stored and organized in the appropriate healthcare data management repository. So you can see why healthcare data management is actually a base layer to digital health. But once you have all these data and you have all these, once you have all these digital technologies, right, you know that they have to talk to one another, but they also generate a lot of data. And the human mind alone cannot make sense of all the richness of this data as well. So this is where you actually need the development of appropriate algorithms to look at that. And because of the complexity of such data, AI based solutions, right, seems right to be the most appropriate way forward at this point in time. But if you look at the axis of this diagram, you also realize that throughout these different levels, factors such as the people involved, the stakeholders, the culture and processes, as well as the ethics and regulatory considerations are really important. So in other words, if you want to effect digital transformation, not only do you need, right, the education and the infrastructure to be ready, and also the technology and the models, but you also need, right, to consider, the stakeholder perspectives, talking to people, understanding what they're comfortable with, and making sure that, they are involved, at every step of the way. This is a very important thing if you're thinking about implementation. Okay, so to segue into what I just mentioned about implementation and stakeholder engagement, I'm going to talk about this AI governance project that I alluded to earlier. So this project has a very interesting title. It's about how ready are we to trust using AI in medicine. And there are three components to this. We're looking at compliance to governance, engagement of stakeholders, and integration into medical system. So this is an ongoing project, but I'd like to share with you some of our findings that we've got to at this point. So at this point, we are in the second year of the project and things are getting more and more interesting, all right? So there are three main aims of this project, as I mentioned: compliance with standards. So how ready are we to comply with AI governance standards with emphasis on various regulatory frameworks? What is the engagement level with the key stakeholders? How ready are people in the healthcare sector to use AI? And do patients and the public trust AI? And is enough being done to facilitate AI stakeholder interactions? And finally, integration to ecosystem. If we talk about to regulators and policymakers and also decision makers at the leadership in the healthcare clusters, what do they feel about the technology? How do they feel about the about the interoperability and compatibility of these technologies, right, into the healthcare system? Will it incur more costs? Will it actually have a net beneficial outcome? So these are the three main aims of this project. But of course, the project, right, being very big, I'm not going to talk about all aspects of it. So I'm going to talk about just two sectors. One is on the engagement on some of our clinicians. So I'll start with this segment first. Okay, so this is a survey-based study, and we are looking at the following six attributes. We're looking at expectations. What do the clinicians generally expect about AI? What are their general attitudes towards AI? Do they trust AI and the results it produces? Do they believe in the usefulness of specific AI applications? Do the clinicians accept specific AI-based applications? And of course, we are not just interested in general trust. We want to also devise specific scenarios that are pertinent to different clinical domains. So currently, we are surveying eye doctors, the ophthalmologists, psychiatrists who work in mental health, and gastroenterologists and allied health professionals, particularly the nurses. And I would also like to point out that for this survey, one very interesting thing that we did different from other related works is that we developed a novel instrument that incorporates context in the form of scenarios. Okay, so what do I mean by scenarios? So let me just give you a sense of what the scenarios look like in the psychiatry survey. So broadly speaking, the scenarios will involve 3 or 4 different scenarios involving different degrees of perceived risk. So it can be from diagnosis to prognosis or characterization of disease, and finally to active interventions. So broadly speaking, the surveys will cover this whole spectrum of use of the AI. We do not currently cover operational deployments, because operationals tend to be perceived as very safe and essential anyway. So we want to know if we are going to use this AI directly in the healthcare, what would the clinicians feel, because this acts as a direct challenge to their practice. Okay, so in this case, for psychiatry, the first scenario will involve the use of chatbots for detection and early diagnosis of depression. So in this scenario, the patient receives a diagnosis from a mobile application and reports that he or she may have depression, and the outcome is after assessment by a psychiatrist, it was deemed that the AI was correct. In another scenario, we look at how a machine learning algorithms or AI algorithms can be applied to guide treatment. So in this particular one, used together with EMRs, we want to predict the odds of pharmacological treatment response or resistance and guide choice of psychotropic medicine. So in this one, the outcome is that the AI can indeed guide treatment outcomes, and it can do so earlier. Third scenario is on wearable devices to monitor and evaluate treatment response. And in this case, we basically assay the perspective of the survey taker on the capability of the AI to track and analyze a range of digital signals to assess response to ongoing treatment, including the effects of medication. So we don't have all the data in yet for all the different legs of the survey, but we have completed the first round for the gastroenterology survey, and this paper was recently published in JMA AI. So if you're interested to find out more about how we did the survey, and also the key results and details, please feel free to look at the paper. But I want to just summarize the key findings. So in general, the gastroenterologists and the surgeons who participated have generally favorable attitudes towards AI. The risk perception, however, is confounded by seniority. In this particular study, we found that senior clinicians view AI as being significantly less risky than junior clinicians, irrespective of the scenario. And I think that the findings highlight the intricate relationship between experience and the perceived risk of AI technologies. And I think, this is a stronger effect than the actual technology itself. And so what does this mean? So what we think the results mean is that having more clinical experience may translate to greater confidence in one's own medical expertise and practice, generating more confidence in risk mitigation when new technologies are introduced. So we think this has to do more with confidence and experience rather than the fear or the concern arising from the technology as well. Now, but very interestingly, we have also recently started looking at the nursing data in gastroenterology. And we find that senior nurses also seem to be more favorable than junior nurses as well. I think that the fact that senior clinicians are more accepting as opposed to junior physicians, this could also point to a general lack of AI familiarization and training in medical education. And this is why why junior doctors perceive AI as more risky than regular or traditional practice. So if you remember the Bloom's digital taxonomy, you remember the digital literacy forms the base layer. So it seems that younger doctors, who are fresh into practice, they view these technologies with a lot more apprehensiveness. And also, this is a point that I already mentioned several times, but I do think that the confidence of senior doctors may have more to do with self-assuredness than the ability to properly judge if an AI is indeed safe or useful. In fact, the fact that we don't see any active discrimination across the scenarios, is a point of concern in itself. And I also, finally, I want to say that I don't think surveys alone, truly capture how people really relate to or interact effectively with AI in real world settings. And I think if we really want to hold people's actions to their words, or how they fill up the survey, then I think we need to move into simulation and enactment research. So with that in place, right, this is our upcoming future plan. So as I mentioned earlier, we are going to set up the new Center of AI Medicine, and one of the facilities that we will be featuring is a living lab or a simulation lab. And this simulation lab will involve a control room where we can actually monitor what's going on, in different clinical enactment scenarios. So this can be in operating theater settings, or it can also be consultation settings. We are looking at a few different scenarios, but for now, consultation and operating rooms, right, come to the fore. Yeah, and so this is an example of what a simulation could look like. So in this case, right, the doctors, right, will be in the room, and then there will be a randomized trial or a controlled trial where some of these simulations may involve, right, a standard computer terminal. Others, right, may involve the incorporation of a language model or an AI that could potentially partner with the clinicians in informing them, of the necessary information so that they can make a more informed clinical decision and also formulate an appropriate treatment plan. Okay, yeah, and I think one of the reasons why we're really inspired to do this was also because of our visit to Melbourne a year ago, where myself and some of my colleagues visited kids and colleagues in the valedictorian. We see that there is a lot of very interesting areas for mutual synergies. And we looked at how you guys, right, are thinking about field testing, incoming technologies, and you want to take it through various cycles, from sandboxes to live deployments or limited deployments. I think being able to do this and in our case, right, focusing on AI technologies, right, could be something that is very interesting that we can explore further. So for us, the reason why we're setting this up is because we want to understand how perspectives towards AI, and technology corroborates with actual use behaviors. And we want to understand also how AI or technology can function as a team member, or especially, and how they actually can effect useful and meaningful human-machine interactions. Okay, so now I want to talk about developers. I myself, right, as an informatician, right, I feel that developer perspectives are important. I don't know about the rest of you, but when we looked at the literature, I do feel that there is a lack of information in this area, which is surprising considering that these are the people who are building the technologies and the AI, and there seems to be very little research on how much do they know about regulatory guidelines and frameworks and whether they adhere to this. Now, this was a survey that I launched a year ago. We had about 100 responses. I have to add that it is extremely difficult to get developers on board, especially those who are in private institutions or in industry. I think probably because, right, there might be some embargoes on whether they are indeed allowed to take these surveys. But nonetheless, we tried and we got some responses. So this survey that we designed captures 6 dimensions. The first dimension is the demographics. Where do they come from, and how many years of experience do they have? Their awareness of frameworks. Do their organizations adopt any regulatory frameworks? What are their personal attitudes towards regulatory frameworks? The ethical priorities of the developer, and whom should hold responsibility for the developed AI? So we look at these 6 dimensions. So this is not yet published work, but I do see some very interesting findings, all right, that I would like to share with you. So I'm going to show you 2 results here. So the first result is on the question, who is responsible for the developed AI? And surprisingly, when we look at the charts, we were quite amazed because many of the respondents actually indicated that the medical AI developers should be held responsible. Now, I'm not sure this is true for all AI developers, but we were quite surprised, right, to see at least the AI developers themselves, right, do not see themselves as a passive vendor. Rather, they feel that they should assume the most responsibility, over the doctors and the task providers to ensure the smooth implementation of regulatory process in developing safe medical AI. Okay, so the other question is, what concepts comes to mind, when we asked you about regulatory frameworks, and and so I'm going to show the word cloud here. You'll be surprised to see, right, that people don't necessarily read the question properly. So not sure why, but when we asked them what concepts come to mind, the biggest and most consistent word that came out was necessary. So in other words, right, if you are going to interpret this, very directly, it just meant that many of the respondents felt that regulatory guidelines and frameworks are necessary. Okay, but that's actually not the concept that we were looking for. But it's good to hear that they feel it's necessary. But if we look at concepts, right, you'll see that trust, safety, and privacy are priorities amongst developers, which is not unlike, concerns, right, that are expressed by practitioners in the medical field. So what else do we know about AI developers? So we know that about half of the developers are aware of any regulatory frameworks, and organizations that adopt frameworks see higher familiarity. Senior developers are more aware of more frameworks compared to juniors, but are no more familiar. Developers feel that they should assume the most responsibility over doctors and task providers. And finally, privacy is the most oft-cited dimension amongst regulatory guidelines. However, many other dimensions are completely missed, highlighting important gaps. Okay, so what does this mean, right? What I think this means is that, there is a need to engage developers more, and there is also a need for better education and informed training, because many developers are actually not trained about guidelines in school. And certainly, right, the senior developers, right, while they know of more frameworks, they are not more familiar about the frameworks either. So this means that there is a gap. And a lack of familiarity also means, right, a lack of adherence or a lack of capability, right, to incorporate these frameworks into the AIs that they're developing. So I think the inclusion, right, into education is a very important thing to have. So key takeaways: senior clinicians are more likely to accept AI, whereas junior clinicians are not, and this suggests an experience and familiarization gap. And I think some interventions may include strengthening the undergraduate digital literacy training and trial communities of practice. Developers express a desire to be more closely involved and want to be held responsible for the technology they develop. Closer conversations and bridges need to be built. And I think that, there needs to be a closer collaboration and engagement between clinicians and developers and engineers to align on safety, privacy, and trust. We'll be talking about patient and public interfacing and also regulator perspectives, right, in the future. We are in the midst of collecting this information. So a little bit of advertisement on what's happening in Singapore to effect, this what we have found so far. So the center that we want to build, the Center of AI in Medicine, will be a multidisciplinary collaboration between clinicians, scientists, engineers, implementation scientists, educators, and social scientists. We want everyone to work together. And of course, when we talk about working together, we don't just talk about it. We also want to make our program sustainable and to build these engagements, right, into our various research trusts and initiatives. So every program will be co-directed by one clinician and one developer or social scientist. Okay. In terms of partnership, we're looking to learn, from a variety of different nodes and partners. So of course, Melbourne included, but we have also been talking to industry, UBC, and also to Yale, and hopefully, right, by building various communities of practice together, we can learn together and also see how we can synergize and strengthen our findings as well. And I think one very interesting enabler is the establishment of our national data banks. So this is the MOH Trust platform. It is meant to be a safe environment for tapping and looking into research involving national electronic medical records. And this is not only just medical, it is also linked, right, to various other data banks, in the government sector as well, which includes information on your housing, your financial statements, and all so on and so forth. So you can imagine how powerful this can be. All right. So in the next segment of my talk, I want to go into leveraging prior knowledge. Okay, so I'm sure you all have seen this picture before, and you've heard about the fable of the blind man in the room, each groping, different parts of an elephant, and then each coming to their own conclusion on what they are feeling, right? Because they're left in the dark, all they have, right, is the immediate information they have in front of them. And because of that, right, they each come to various absurd conclusions, but none of which is actually the animal involved, right, which is the elephant. But we can also look at this, right, from another perspective. Okay, so I think this fable has a parallel also in AI and tech development. When we are developing something, sometimes we could be misled by deep details. And I think applying prior knowledge or exploiting current information can add a contextual layer that improves the findings and also helps to avoid error. So in this case, right, if the blind man have a contextual cue or contextual clue, such as, oh, this is a large land animal, right? Then they may be able, right, to constrain, their thoughts, and more easily come to the conclusion that what they are feeling is indeed part of an elephant. So the reason why I want to talk about this is because tech development, looking at the data they generate and then building models, right, to perform useful tasks, right, on these data, it's a very arduous process, and it can also be a very error-prone process. And these potential errors, especially in a high-stakes field like medicine, is what drives, a lot of concerns. And a lot of times, right, people thought about, okay, if we want to reduce bias and we want to maintain safety, it is really important to keep the human in the loop. So the human in the loop basically, right, can be in many forms. It could be active, where you are actively navigating the decision processes of the model and attenuating it, especially when it is hallucinating or making errors. Or it could be passive, in the sense that you make some prior decisions on how the machine or the model should deal with data, or you make prior decisions on what information or what features are most useful. So this active and passive process of inputting human intelligence into machine intelligence, I think is what could really make a significant difference. But I will also say, right, that applying human intelligence into machine intelligence is not a very simple or straightforward concept. I mean, certainly when you talk about the human in the loop, right, what it seems like a very sexy concept, you realize that once you put the human into the process, you realize that there's a lot of data, there's a lot of decisions, and there's a lot of things that you may not have immediate access to. And I think that's what is one of the key inhibitors, of how can we extract the human intelligence into the machine decision-making process. But I also like to say that the human can make a decision on what data is or what features is most useful. And where there is a huge amount of information or a huge amount of decisions to be made prior to the formalization of the model, then this process, right, can also in turn be aided by AI. So I would like to give you some examples from some of my existing work to show you how existing data and existing knowledge can be exploited. Okay. But before I want to go into that, I just thought this diagram is a good way to segue into this process. So if you this is basically a very simplified map into the various steps into building a model. You realize that even the data processing steps itself can be a very arduous process involving many key decisions. Okay, so one way in which the human intelligence, right, can be better aided is to leverage or exploit existing data and know-how. So in this particular work, right, what I wanted to know, right, is whether optimality is predictable. In other words, right, if I want to build an AI or I want to build a workflow to perform a particular task, whether it is to predict, it is to build an AI to look for potential biomarkers, or whether I want to build an AI to guide me, on how to build, right, an optimal workflow or pipeline to do some task. Then one way that this can be done, right, is that we can look at existing data, and we can look at various permutations, and then we can see based on the labels that are tied, right, to the performance of these various permutations, how, what are the patterns, or what are the properties that are conserved, that we can exploit and that we can apply, right, for our own intended purpose. So in this particular work here, what we wanted to do is that we wanted to build an AI that can actually tell the user how to best analyze their data, to look for protein biomarkers. And we basically built this model, right, based on thousands of permutations on existing benchmark data sets, such that, all the user has to do, right, is to say, okay, I have this data, it is built on this platform. Tell me, what do I have to do, right, in order, right, to get the best coverage or the optimal set of biomarkers in my data. So in this way, right, we can actually use, right, the data that we obtain from current information, current knowledge, right, to actually guide that decision making before we actually build, right, these kind of predictive models formally. So if you're interested in protein biomarkers, please have a go at the website, and also do take a look at the paper. I think it could be very interesting. Okay, another way, right, you can use prior knowledge and to help to improve your decision making is to exploit the associations across different modalities to elevate each other. So, people talk about multimodal foundation models, although they talk about data integration, they talk about data-rich processes. But I think that the human intelligence component, right, is really about identifying, which data modalities can talk to each other, which data modalities are synergistic and can elevate each other. So in this particular example, right, we are using two different sets of prior knowledge. On the left side, we wanted to use information based on protein networks or protein systems to inform on what kind of proteins are actually present in a particular sample. Okay, again, this is on protein biomarker discovery. But because we know that proteins, they don't work alone, they work, right, as networks or systems and complexes. And we also know that spectra basically, right, it's just giving us a glimpse, right, into, small peptide fragments, small protein fragments that exist in any sample, right? It's extremely noisy. So what we want to do is that we want to basically exploit, right, the fact that proteins work together, and any spectra that belongs to a protein must therefore, right, be present together, right, to form the relevant complexes to enact or effect specific functions. So because we know this information, we can actually use, right, the network information, right, to rescore, the spectra, to clean up the spectra and find out what kind of spectra corresponding to proteins that should be present in the sample, right, should be there. At the same time, right, we can also use this information to clean up, right, our previous knowledge or prior knowledge on protein complexes and protein networks, so that, in this way, right, we are able to clean the spectra, but at the same time, we're also able, right, to increase our knowledge, right, on protein networks. So in this way, right, the different modalities actually elevate each other. We can also do the same thing with gene information and proteins, because genes are essentially translated into proteins. So if we want to know, for example, in this case, what proteins are missing in a particular sample, and I know that, and I have, right, the relevant gene network information, I can actually retrospectively work out what proteins are present and how much of the proteins, right, should be present as well. So if you're interested in understanding, the contextual leverage that we are building into these two algorithms, please feel free to look at these papers and also play with the software that's incorporated in the link here. Yeah. So this links back to digital health, right? Because as I said, there's a lot of ongoing projects in digital health, and one of the very exciting new projects that we have, right, is a digital mental health project to monitor mental health on campus. This involves the use, right, of digital sensing using wearables and smartphones. And there will also be a one-stop mental health platform intervention. So this study will be recruiting about 500 university students. The recruitment is still ongoing, so there's no data yet from this study, but it will be a long project, and it will incorporate a 4-month observational period to see whether or not, right, the models can actually predict, the onset of depression or anxiety events amongst school-going children. But I think, all right, that we can potentially enrich the digital health data by identifying risk factor typologies. So the concept, right, is to use existing data sets from cohorts with similar social demographics, exploit the data to find ways to cheaply and conveniently evaluate the risk factor of every student, and then see if the digital marker is better fitted to the risk factor typologies and can be used synergistically. So this is a study that I'm involved with. This is the LYRIC study, and it is a prospective observational study conducted in Singapore on youths aged between 14 to 29 to assess risk factors for psychosis. And participants were recruited from psychiatric clinics, various community agencies, including educational institutes and social services. So in this very rich data set, I also have a variety of information from biomarkers, from the multi-omics to behaviors and social demographics and so on and so forth. And of course, we're not only just looking, right, at schizophrenia or psychosis. We are also interested in depression, anxiety, bipolarity in this cohort as well. So because we have these other labels, we can actually use, right, some of the data to generate some typologies that we can then apply prospectively onto the digital health study that I showed you earlier. So when we decided to relook at the various features in the data set, we realized that two features, right, could be very useful and telling. One is on parental bonding index. So based on parental bonding index, we can actually identify 3 groups for which you can see 2 higher risk groups and 1 low risk groups, which are enriched for depression rates, and 1 group, right, that is generally low depression rates. And the baseline depression rate is at 0.13. So we know that depression rate of 0.21 and 0.22, right, would be higher than what is the baseline average. Okay. Another interesting feature that we can look at, right, is on social function. So this is a simple test where we can actually just ask the respondent, a question, and we see how they respond, and we can perform text analytics and then the like to see, to look at indicators of socializability. So in this case, right, you can see the grouping is even more pronounced here. You can see that in this data set, there's 1 high-risk group with a very high depression rate of 0.53 and 2 relatively safe groups at 0.06 and 0.09 respectively for depression. Okay. So what I think can be done here, right, is that we can exploit prior knowledge to improve the outcomes of these digital health studies. First, we can use, right, or exploit, right, these independent parallel data to get these typologies, which can be easily constructed, in our prospective cohort. We can then incorporate these typologies into the existing digital health study, and then see whether these typologies can better explain variation. In other words, right, the machines, the technology itself, right, may not be the issue here. The human heterogeneity or the clinical heterogeneity may be the problem here. So if we can account for these, right, then the fit to the data would be better, and we will be able to explain off, right, any unusual events or any subgroup events better, because we know, that these individual students, right, would be at higher risk anyway. And of course, I think here, right, if we can combine, prior data well with the digital health data, I think we can significantly improve outcomes. And this can also give us a means, right, to focus on high-risk groups, right, early on, rather than wait for the digital signature, right, to become pronounced before we decide that, okay, you are a likely depression case and we should rope you in. I think there is a way, right, to do this in a more and in a more clever way, and I think that's where human design and human intelligence can come into play very well. Okay, so key takeaways. I think AI and tech development can benefit from exploitation of prior data and knowledge. Use the existing data to figure out what works best for your problem. Study which modalities can mutually reinforce each other and exploit them. And finally, set up priors that can enrich your digital health study and better account for heterogeneity in real-world populations. All right, and for the last part of the talk, right, there's no data to be involved here. This is an ongoing paper that is currently under review, but I thought it'd be good, right, to share a little bit with the audience here as well. So I like to think, of the advanced deep learning models, right, as learners, not human learners, but virtual or digital learners. But let's talk about human learners first, all right? So when you teach your students in class, how do you normally evaluate them? Okay, so I give you two options. One is you give them a test or you open up their brains. Okay, so I think those of you, right, who are not Hannibal Lecter wannabes, right, will certainly choose the first option, right? We give them a test because opening up their brains, right, is illegal, right? And we can't do that to humans. But what if we are talking about an AI model that you train, right? So in this case, right, can you give it a test or can you open up the brain? Now, interestingly, right, in the AI and the digital field, right, both options are viable, right? The first one, there are some techniques for it. They call it cross-validation and independent validation. So this is performed very widely, and I'll show you an example of this in a little bit. But of course, there is this other part about opening up the brain, the digital brain, because the AI is not perceived as an individual yet, they are not regarded on the same level as a human being. So because of that, right, the topics of interpretability and explainability can come in. But as with the more advanced models, right, with trillions of parameters, or very, very, very hidden layers, right? It is really difficult, right, to even open up the virtual brain these days. So, in other words, right, the second option, right, even though it's not illegal, right, it's also becoming increasingly challenging as well. Okay, so I would therefore say at this point, right, I think, like the human, the test is easier to administer than it is to open up the brain. Okay, now. However, right, the reality is that currently we are better at designing tests for humans than for AI. I hope, okay, at least for all those of us who are involved in education, and I hope that you're giving sufficiently challenging tests to your students so that you can really show that they are learning well, okay? But in the AI area, right, you will see ROC curves and accuracy, F1 scores and G scores, right? They are near perfect, and these are really, really amazing, especially when you see these on a brochure or a publication, you'd be like, okay, this is fantastic. And then the next question you ask is, what's next, But I also have to say, you should not forget, right, that just as humans do well on easy tests, so does an AI. And I think one thing that we really need to pay attention to is, again, right, keeping the human in the loop, applying human intelligence to machine intelligence, giving the AI.
Sorry, I've just dropped that.
Sorry? Giving the AI a challenging task and then see whether or not, right, it has really learned well or deeply, all right? So without going to too much details, right, I just wanted to give you some tips and guidelines. So the first thing I want to say is that you should take control over your test questions, and use this to infer the learning quality of your model. There's nothing in the rulebook that says that you cannot do something to curate or to incorporate information into your training and your test sets. So in other words, right, use design to create problems or various challenges so that you can actually figure out, right, whether an AI is doing well only on easy problems but not hard problems? Or alternatively, right, is your AI only capable of working on hard problems but not easy problems? I mean, both, right, will signify different issues, right? The first one, okay, if it does only well on easy problems but not the others, then you know that it is a superficial learner. It has not learned anything meaningful or useful. But if it works only well, right, on hard problems but not easy or moderate issues, then you should be careful as well, because it is very likely that your training data is probably biased towards such hard problems. All right, so you can use design to actually guide your interpretation of what the performance metric really means. And I also like to say, right, that if you are going to design your problems, right, don't look just at the aggregate, because it is very difficult, right, to find a even distribution, right, of easy to moderate problems. In fact, I would argue, right, that finding hard and challenging problems, right, may be very difficult. And of course, if you only challenge, right, your AI on only hard problems, right, you may not be being very fair as well, because whatever, right, you use to challenge the AI with, right, should also be representative, right, of the distribution of easy, moderate, and hard questions in real world data as well. All right. Okay. Now, this is another point that you need to be aware of, which is on batch effects, and also, the outcomes, right, of data normalization or data processing. So every time, right, you challenge your model, the samples, right, that come from that new model is effectively a new batch, which means that it has a different technical or source variation attached to it. And because of that, right, you can never be certain whether or not your model is actually robust, towards these various batch effects. So in other words, right, if you have designed your model well, you also incorporate, appropriate data processing methods, right, your model should work well or relative or sufficiently well, regardless, right, of any of new data that comes from any new future batch, okay, whether the data comes from, for example, Australia or Singapore or New Zealand, for example, okay. So one way to get about this, right, is to try or design your challenge to have data that comes from different batches, different sources, and see, that your model is still able, right, to give you the correct answer, irrespective of the source. Then you know for sure that your model technique and also your processing technique, right, is appropriate and is resilient towards these technical artifacts. Third part that I want to mention is don't just trust your test results blindly. See if you can outperform chance. So a lot of times, right, when people report the performance metrics, they will usually just report, for example, a flat 95% accuracy, or they'll just report, right, a simple AUC. But it is very important, right, to also see whether or not you can actually see similar results based on permutation of your data. Because if you can indeed see similar results despite the permutations of your data, then you will realize that good performance, right, is a given. It is not because of the quality of the learning, all right? And the last point I want to add here is that you should not trust any single evaluation. Think universally. Don't just think that a simple single external validation is sufficient. You should test generously and widely. Try to see, what kind of data sets do your data not work on, and if they don't work on certain data sets, why is that the reason? Okay, so in other words, right, you should not be just looking for universal good performance. You should also look for subsets of poor performance, because that will inform you on what needs tweaking, okay, or whether there are certain subgroups, right, that needs the dedicated treatment, or perhaps another model to deal with them, all right? So I think that's to really deep dive more into the specifics of the data and the domain, rather than just assuming that, you can have a one-size-fits-all model. So the key takeaways: you should design your training and validation data to include different levels of challenges. Design your training and validation data with intent so that good or poor performance can be explained. Ensure that your model is robust against batch or technical effects. Validate your models exhaustively. And given these various tips, right, know what question to ask your engineer or clinician so that you can develop better and safer models together. So in summary, we have looked into multi-stakeholder perspectives. There's a need to bridge or engage clinicians and engineers. We show the value of incorporating prior knowledge and data before modeling or initiating a digital health trial. Test your model rigorously. Don't just rely on a single metric. Bring meaning to the metric by intentional design, and be very defensive to work out what the model has learned. Yeah, and I would like to acknowledge and thank my team for supporting me throughout these few years. We have really just started on this, and I hope that we will have a lot more results to show in the next few years. And with that, thank you so much. Thank you.